And you should all get, there you are. So, welcome. Thank you, Miss Richardson. Over to you.
Okay, well, thank you very much, Pravina, and good evening to everybody. Just a little, really, an update and reminder of the features of diabetic retinopathy and really why we're here and what we do in retina. Diabetes takes an enormous amount of time in our retinal clinic, so just some background and some pretty pictures, I think. Why is this not? Oops, sorry. So I'll do an introduction. I'll show you the characteristic features of diabetic retinopathy. I'll show you the grading systems that we use, the factors that influence the progression of diabetic retinopathy, and then the most important thing from our point of view, what we do and how we treat it. So diabetes, the problem. Well, you only have to listen to the press to know the problem, because we're all getting fatter and in the Western world. So 3.5 million people diagnosed in diabetes in UK. This has increased from 1.4 million in 1996 and is estimated in just a few years to be 5 million. So it's a big problem. It's the commonest cause of visual loss in the working age population. And this is our problem, your problem and my problem, that many people are asymptomatic until the disease is advanced. And so trying to get over to them that actually, despite the fact they're 6'5", they've got treatable and diabetic disease that needs treating can be quite difficult. 20 years after diagnosis, 60% of type 2 diabetics have diabetic retinopathy. So lots of features that really make me think diabetes: microaneurysms, hemorrhages, vascular changes. Very important. I spend my time saying to the junior doctors, look at the veins, look at the veins. Exudates, cotton wool spots, neovascularization, and then your retinal edema. So microaneurysms, that's a lovely picture with some lovely little microaneurysms dotted around there. Really very typical of diabetes, microaneurysms. Dot and blot hemorrhages, extremely typical. Basically, if you see dot and blot hemorrhages, it's diabetes until you prove it's not, because you don't see those sorts of hemorrhages so much in hypertensive retinopathy. Hypertensive retinopathy tends to cause flame hemorrhages, much more superficial in the nerve fiber layer. So hemorrhages, again, lovely dots and blots there going through the retina, very typical. And you can see on the I don't know if I can move my cursor. Oh, yes, I can. There we are. And there's a lovely vein going through there, which is, you can see, is a bit irregular and a little bit beaded there. Just think string of sausages, roughly speaking. But that's a rather beaded vein and rather typical of a diabetic retina. That looks very troubled, that retina, really, I'm afraid. Sorry. So here we have vascular changes. And again, you can see the vein going across in the middle here. This vein is very beaded. You can see, I mean, this does look like a string of sausages, doesn't it, really? All the way across here. And then you've got this very, very sort of featureless area of retina here with lots of dots and blots. That's featureless because it's lost its capillaries. You compare it to here, and that looks quite pink and healthy, and that's rather sort of creamy and unhealthy. And I suspect if you did a fluorescein, you would just have a big black hole there. It would have no supply of oxygen at all, because it's a disease that affects the small blood vessels, and it's a disease that causes closure of small blood vessels, particularly in the mid-peripheral retina. So you get ischemia in the mid-peripheral retina. What I always say to the juniors is look at the veins and look along the horizontal raphe, because the horizontal raphe is the watershed zone. You've got vessels coming from the top and vessels coming from the bottom, and in between is the area that is most prone to ischemia. So again, you've got your vascular changes here. You can just see here these flat intraretinal intraretinal microvascular abnormalities. These are just channels, normal channels within the normal retina that are opening as a response to ischemia. So the retina's, it's very simple. It's like a bypass, you know, the retina's screaming, give me more oxygen, and it's opening up all its capacity. So these are microvascular abnormalities, very typically seen between arteries and veins, flat. And if you did a fluorescein angiogram of those, they wouldn't leak, not like new vessels. So this one, you get 3 for the price of 1. So you've got exudates here, these lovely little hard exudates. These are just a tide mark. They are lipid-rich deposits from leaky blood vessels. So this is where a blood vessel is leaking, probably this little microaneurysm or here, and you get this leakage of exudates. Here you've got a cotton wool spot. These are cotton wool spots. Cotton wool spots are signs of axonal ischemia. So the nerves are ischemic. They show that you're ischemic. And then here, sitting very nicely, is a big tuft of new vessels. New vessels in diabetes always come off the veins. So here we are, here's the vein. And they branch off, and you've got this area of fan-like of new vessels. If you did a fluorescein angiogram of those, they'd leak like bilio. They really would leak. And these are the things that we have to try to get rid of, because the new vessels in diabetes are flawed. They are accompanied by elastic pools. So if you just leave those to develop and do absolutely nothing, the vessels will proliferate, they will bleed, and you will get a tractional detachment. So they are just not good news. So how do we grade diabetes? And there's a lot of different ways to grade diabetes. We obviously, in diabetic screening, they use the R1, M1 grading, and that is R1, R2 and R3, and M0 and M1. But this is just a simplified version, really derived from the early treatment of diabetic retinopathy study. That study is about 30 years old, but it's a real gold standard for diabetes because it was a huge study done in the States. So non-proliferative diabetic retinopathy, you'll sometimes hear us calling it NPDR, because we're a bit too lazy to say non-proliferative diabetic retinopathy. We follow the 4-2-1 rule when we grade. So 4 quadrants of retinal hemorrhages gives you a point. 2 quadrants of venous beading, that string of sausages, gives you a point. And 1 quadrant of ERMA gives you a point. So as you can see, if you have no points, you have mild non-proliferative diabetic retinopathy. Your rate of progression to high-risk proliferative diabetic retinopathy within a year is 1%, and we would discharge those patients to diabetic screening. Moderate, you've got 1 point and the corresponding numbers. Severe, and then very severe. Very severe is you're tipping into proliferative. You're not there, you're not proliferative yet, but you are tipping towards it. So then proliferative retinopathy is defined by the diabetic retinopathy study high-risk characteristics. So very few of the proliferative retinopathy patients that we see are low risk. And low risk characteristics are new vessels elsewhere, so not at the disc, not within a disc diameter of the disc, and they are less than 1/4 of a disc diameter, so they are tiny. You can observe those, but it would have to, or I can, you can't, but I can observe those in my clinic. But they would have to be a very compliant patient. If you think that the patient might not return, then it's better and safer to laser them. The high-risk characteristics of proliferative diabetic retinopathy are any significant new vessels at the disc, or vitreous hemorrhage, pre-retinal hemorrhage, or significant new vessels at the disc, or minor new vessels, significant vessels elsewhere, or minor vessels at the disc. And I'll try and show you some examples. So I think we can all see the disc there with lots and lots of vessels coming off it, branching right out into, you can probably see here, out here, even out here, these are all new vessels covering the disc. Very, very significant proliferative retinopathy. There's your classic pre-retinal hemorrhage, boat-shaped because the blood gets trapped between the vitreous face and the retina. So you've got this funny boat-shaped hemorrhage, very typical. And you can see it's pre-retinal because you can't see the blood vessels through it. It obscures the blood vessels. lovely examples there of new vessels elsewhere, and this picture shows you lots of exciting things actually. So here, up here is the disc, and you can see that this is a huge frond of new vessels coming off the disc. They're flat, but there's enormous tufted vessels coming off the disc. And then you come down here and you've got new vessels elsewhere, big tuft with some bleeding, and new vessels elsewhere up here. And if you look, you can see why those new vessels are formed, because if you look here, you can see this vein here is completely blocked. It's completely gone. It's completely closed. And so the retina is ischemic. It's releasing growth factors. The growth factors are stimulating neovascularization. So then we have to talk about the other very important part of diabetes, and that is maculopathy. So the macula is the portion of the posterior retina containing xanthophyll, the yellow pigment. That's why it looks like the yellowy pigment, and more than 2 layers of ganglion cells. It's 5.5 millimeters in diameter. It's really quite large. Within that, the fovea is the depression in the inner retinal surface at the center of the macula, and is neatly is a disc diameter. And then the thing that the medical retinal world is obsessed with, which is the FAS, the foveal vascular zone. You'll hear us talking all the time. What's the FAS like? And why is that? Because if you get ischemic, you can't laser into an ischemic foveal vascular zone. If you laser in an area of ischemia in the macula, you will decompensate the fovea, and you can take someone who's teetering along at 6'9", laser in there, very ischemic foveal vascular zone, and you can take them down to 660 and they won't recover. So the FAS is very important to us and is 500 to 600 microns. So maculopathy can be diffuse, focal, or ischemic. And the key thing, the most important term that we use, and it depends whether you are on this side of the Atlantic, you'd call it CSMO, I beg your pardon, or CSME if you're in America. And that is retinal thickening within 500 microns at the center of the macula, and or exudates within 500 microns of the center of the macula, accompanied by thickening. You're not just treating exudate, or zones of retinal thickening of 1 disc diameter, part of which is within 1 disc diameter of the macular center. And of course, OCT has made that so much easier for us, because we can look at the pictures and look at those, green and red and blue pictures and see exactly where we are. So there's a nice example of focal maculopathy. You can see here some exudate up at the top, and probably there's an area of leakage. We haven't got an OCT for that one. And this is another lovely area of focal macula. This is a typical cercinet, ring-like exudate coming out from these microorganisms that are leaking. Here we go, and another one, and one centered on the fovea. This one probably isn't clinically significant because it's a long way away from the fovea, but this sure as heck is, and this probably is. So what are the factors influencing diabetic retinopathy? Well, diabetic control. We all know that if you don't control your diabetes, you have a much higher chance of developing complications of diabetes. Blood pressure, that's extremely important as well. You need to keep your blood pressure tightly under control if you're a diabetic, and it's very important to do so, because any ischemic drive will worsen your diabetes. Pregnancy, the pregnancy hormones can drive your diabetes, so we keep in diabetic screening, they keep a very close eye on pregnant women, and if there's any sign of any retinopathy, they get referred and watched very closely. Smoking, again, it's due to the ischemia, it's due to the effect on the vascular tree, and surgery. So diabetic control, improving diabetic control reduces the incidence and progression of diabetic retinopathy. And the evidence for that comes from the Diabetic Control and Complications Study and from the UK PDS. So, just reducing your HbA1c by 1% can result in 37% reduction in microvascular endpoints. So the diabetics, they hear us nagging them about their HbA1c, but that's why. Blood pressure control, again, evidenced from the UK PDS that tight control, again, weirdly leads to the same number, 37% reduction in microvascular endpoints. And every 10 millimeters of mercury reduction in systolic reduced the need for laser by 11%. So it's extremely important that diabetics control their blood pressure, and that can be quite difficult, and it's important to get it over to the GPs. Pregnancy, as we mentioned, can cause progression and needs a careful follow-up. Smoking didn't have any negative effect in the UK PDS, but it stands to reason that it's an ischemic drive, so I would advise against it. And ocular surgery, definitely you have to be careful when you do a cataract operation. If somebody has significant maculopathy, that macula will get worse. Every diabetic macula develops a degree of swelling after surgery. Usually, if they've got minimal retinopathy or no retinopathy, that just resolves before we see them after surgery. But if they've got significant maculopathy and you operate, we would have to warn them that it is likely that their diabetes will get worse. Sometimes you have no choice because you can't see the retina. So high-risk proliferative retinopathy requires PRP, or pan-retinal photocoagulation. That's the sort of scatterbombing of the retina, the mid-peripheral retina. And what you're trying to do is to reduce the ischemic drive, reduce the drive for producing the VEGF. It does convey a significant reduction in severe visual loss over 2 to 3 years, but it has side effects. Obviously, if you burn the retina, you affect the visual field, and that can affect the driving. We've got, techniques have advanced a lot before. I mean, if you're as old as I am, you'll remember xenon arc laser, which was where you'd white out the whole of the peripheral retina, and you just have this little tiny island of retina. We've advanced since then, and we try to put on as little as we can to hold the disease. Probably the first session of PRP for a patient would be 1,600 burns to each eye, and then we would see some people will need 7,000, some people are held at 1,600. But PRP in a type 2 diabetic will increase the macular edema. So if you've got macular disease and proliferative disease, the best thing to do is to treat the macula first and then do the PRP. Otherwise, you run a risk of a very unhappy patient, because they will have, unless they've bled, they will have almost no symptoms for their new vessels, but they'll have a lot of symptoms if their macular edema gets worse, and they will hate you. So this just to show you that this is a very old slide, but it does show you how the laser does work. On the left-hand side of the screen, you can see the new vessels all over the disc, coming all the way down. You've got some hemorrhage there just in front of the vessels inferiorly. And then on the right-hand side, you can see the PRP scars coming close into the disc. That's quite big PRP scars. We probably wouldn't do those quite so big these days. And you can see the vessels are just fibrosed. You can just see a ghost of them. That ghost is fine. That's absolutely fine. You won't get them to completely go away when they're as big as that, but you will get that fibrosis, which is the key thing that we're looking for. And those are lovely PRP scars. Again, that's coming in quite a long way nasally. We're trying to preserve that visual field, so we probably wouldn't come in as close as that nowadays. But those are very typical PRP scars. As I said, low-risk proliferative retinopathy can be observed, but with exceptions. If we have any doubt, if I think a patient is not going to attend, I would treat them. Better to treat than to let them get worse. And for treatment of diabetic maculopathy, CSME is the key. So focal laser is a very safe thing, and we have all these injections, and I will talk about injections, and they are very good. They're very, very good at treating retinopathy. But when you stick a needle in somebody's eye, there is a chance, a small chance, 1 in 2,000, of causing endophthalmitis, which can be devastating. And the diabetics are the most at-risk group for endophthalmitis from anti-VEGF, because they are immunosuppressed. It's a nature of the disease. Their disease immunosuppresses them. So if you've got those circinate exudates within the macula but not affecting the center, you can use focal laser, and this is very safe. It reduces the moderate visual loss by 50 to 70%. Grid laser we use much less these days. It can have an effect though, and what you're doing with grid laser is very, very light burns. Really, basically, you're trying to kick-start the RPE pump to clear the fluid. Grid we use much less these days. Now we've got anti-VEGF. If there is no thickening and the macula is ischemic, there is nothing we can do. We cannot give you back the blood vessels you've lost. So this again is a before and after. So you're the one on the left-hand side with all the exudate, you've got a huge circinate there, and the one on the right, you can just see some laser burns, very delicate laser burns coming near the macula, and that exudate will take quite a few weeks to go away. So don't expect the exudate to go away. You're just waiting for the exudate slowly to go away, but it's the fluid and the thickening that you're interested in. So anti-VEGF. You know, we have entire clinics full with patients having injections. It is the only treatment for diabetic macular edema involving the center of the fovea. As I said before, if you laser into the center of the fovea does not like that at all, and you will reduce the vision immediately. So the key number for us is a central retinal thickness, a CRT of more than 400 microns. We usually use Eylea or aflibercept as our first treatment, but with no response, we can try either Lucentis, Ozurdex, and now actually we can try faricimab, which is the new kid on the block. Faricimab is the hype from the drug company would have you believe that you can have intervals of up to 4 months. We will see. It's not really been used in many clinics yet. So this again shows you what does it do. And these are old-fashioned OCTs, I appreciate, but you've got, so at the top you've got a thickness of 674, a nice raised macula with cysts in the center. You've treated it and you're getting down to 403. That's all looking lovely, happy days. And then at the bottom you can see 217, looking much more like the macula that we know and love. So if you the two types of diabetes do vary slightly, and a type 1 diabetic, if you treat the proliferative disease, it may lead to spontaneous resolution of the macular edema. Now, the type 1s tend to be younger, and you want, as I said, laser is a destructive treatment. You're burning the retina. So in a type 1, if you treat the proliferative disease and reduce the ischemic drive, you can get a spontaneous resolution of macular edema, depending on how gross the macular edema is at the start. But with a type 2, definitely PRP will worsen the macular edema. So treat the macula first, and possibly you may fractionate the treatment. Again, probably not now, because we have the anti-VEGFs up our sleeve as well, which is very useful. And then there's surgery, and that comes into vitreoretinal clarity, the pars plana vitrectomy, and this is for the severe vitreous hemorrhage and proliferative diabetic retinopathy. And it is clear that early vitrectomy, intervening early, is associated with significant preservation of vision in type 1 diabetics. So we have a very open motorway between the medical retinal clinics and the vitreoretinal clinics, with patients buzzing between them. If they bleed, they go off to the VR people who do a vitrectomy, sometimes endolaser, send them back to us and we monitor them. They also have a role, the VR surgeons, in maculopathy, and that is in the treatment of marked VMT. So there's your VMT, a lovely picture of VMT, and they can, if necessary, release the vitreous face there and allow the retina to settle back down. So just in conclusion, diabetes is a condition on the increase. It ain't going anywhere. It's just going up. And it's to grade it, just think about the changes of the blood vessels. Just take it and calmly look at each quadrant and follow the 4-2-1 rule. It's important to control the external factors, tight blood pressure and glycemic control. And treatment of diabetic retinopathy is very effective at significantly reducing the severe and moderate visual loss. And there's a nice picture to finish.
Fabulous. Thank you so much, Miss Emma, for that. We're going to go straight on to another brief talk by Emma on medical retina referrals. That should only be another 5-10 minutes, I believe.
Yep, I'm just trying to find it. So just talk among yourselves.
Oh, lovely. While you're doing that, can I just remind people to make sure they've got their GOC number as part of their name. So if you don't, unfortunately, I can't get you your GOC CPD points. So please do add your name. If you are having difficulties with that, then please just type your GOC number in the chat and I will add that for you from my end. And also what I want to do is open the floor up to any questions. So if you have any questions for Emma based on the teachings just given, or any questions really, please either write it in the chat and I can ask her at the end, or please do unmute yourself and verbally ask.
Now, have you got that screen? Can you see my screen?
Not yet.
This is very, let me go back in and see if I can get it to do so.
Okay.
Ha. Hopefully this one. Can you see it now?
Yes, we can
Excellent.
see PowerPoint now. Yes.
All right. Would you like me to proceed straight away?
Yes, please. That way we can keep
Okay.
time.
Okay, so Joe and Bavina asked me to give a little talk to you guys about medical retinal referrals, do's and don'ts, just to sort of quantify from your, you don't know what we're doing in the hospital and we don't know what you're doing in practice, but at Queen Mary's, we get on average between 50 and 100 urgent referrals to our eye casualty and to our urgent referral box a day. And in medical retina, we try extremely hard not to see any of those through the eye casualty. And the reason for that is because they are patients who need to be treated in clinics. And the last thing a diabetic needs is 4 hours waiting in eye casualty to see a junior doctor who says, oh, yes, you need to see Emma Richardson, so I'll book you into her clinic. What you need is to bypass the casualty session. But medical retinal clinics do not expand forever. So what we really need is your help to make the system work. Oh God, slides, come on. So the aim is to keep as many patients as possible in the community. It's frightening to come to hospital. They get very scared about what they're, what's going to happen at the hospital. They've got all those horrible needles and shooting lasers and all this malarkey, and they know you're their comfort zone. So what the aim of is to keep as many patients who don't need treatment with you in the community, to maximize the availability of hospital eye service appointments for those who really need it. And we all know who they are. So the do's when in a referral, please supply an up-to-date contact telephone number for every patient. We need, if we get an urgent and I say it's urgent, then we need to ring that patient and say you need to come in. And if we haven't got a number, it's pretty difficult. Look at the patient's age. Is your proposed diagnosis appropriate? It gets a bit tiring when somebody refers query wet AMD in a 25-year-old, because it's not going to be wet AMD. And the same for something like GCA. GCA really is never seen in somebody under 50. So if you've got a 39-year-old with a headache, it isn't GCA. Follow the SPOA guidelines. Now, I'm not sure if they've come out to you yet. I hope they have, but the guidelines are designed to streamline all referrals into all hospitals in South East London, St Thomas's and also King's. Please take a full history. Please tell us if the patient's diabetic, because it's very frustrating if we get, please see this patient with macular edema, and we don't know if the patient is a diabetic, because if they've got diabetic maculopathy, their treatment may be very different to if they've got wet AMD. They may look different, but you may just have retinal cysts, and anything you can tell us is very helpful. If you've done an OCT, if you can do an OCT, please send it in every case. It's no good telling me that you've done an OCT and what it shows me. I want to see it, because when I can see it, I can then triage it effectively. And remember the numbers we're getting through. And of those 50 to 100, 2/3 of them are medical retina. In my opinion, and I know not all practices can offer this, but in my opinion, all macular referrals need an OCT. If you're unsure, send it. I don't know, I think you guys may all be MEX practitioners, but I would say, you know, for the less experienced optoms, please send them to MEX, to the SPOA first, because your own colleagues may be able to say, actually, don't worry about that one. And I used to be, until very recently, diabetic screening lead, and I've had a word with diabetic screening, and they've said, if you see mild to moderate diabetic changes, instead of sending them to me, send them to them, because they can say, oh yeah, we saw them last week and they're fine, don't worry. So there's the email address for diabetic screening. This only applies for the Southeast London. If you're out in Dartford with Kent and Medway, it won't apply for you. Don'ts. Right, we offer at Queen Mary's, we offer a referral only service. Please don't just send your patient without emailing us. You should all have the urgent and RAU emails. Please only email us. We will then sort an appointment out. Those referrals are checked multiple times a day. Your referral will not be ignored. If you email it to us, we will get in touch with the patient and sort them out at the appropriate appointment. It is very frustrating and very sad when an 86-year-old come beetling up to casualty, having been sent to have their wet AMD treated, to be told, actually, yeah, that's lovely, we'll see you on Monday in a clinic. That's very frustrating for them. And sometimes they've paid a lot of money in taxes. Please don't send everything via the urgent and RAU emails, because if they are inappropriate, and I rejected about 6 this morning, they will be rejected and sent back to a single point of access. You know, we can't see dry AMD as urgent, and if we can't see drusen as urgent, please don't send everything via the urgent emails. Do beware of low vision when you're referring wet AMD. If the vision is less than 3/60 in a wet AMD patient, they're below NICE guidelines, so we couldn't treat them. So just beware of that. Don't promise the patient that they can have treatment, because they may not be able to. From the post-operative point of view, cystoid macular edema, King's will only see and treat King's patients. So if your patient has had cataract surgery at Spa Medica or at Czech, we will not see them. So they have to go back to the independent treatment centre or their private consultant or whoever, wherever that may be. We at King's will only see the post-operative complications that we've caused. Please, little plea from everybody, don't refer patients where you haven't examined them. I know that sounds really obvious, but sometimes we get unexplained visual loss, you know, oh, the retina looks fine, but the vision is down. Well, there must be a cause. So please look at the optic nerve, look at and give a full retinal examination before you send them. Pigmented lesions, this is an issue. Anything that, if you think it is a melanoma, and please refresh your memory as to what a melanoma really looks like. They're fairly barn door. If you think it's a melanoma, we will see it that day in casualty as an emergency. If somebody refers 6 melanomas in a day, we'll get a bit suspicious. And every pigmented lesion is not a melanoma. If you are unsure, please refer to MEX or ask a colleague to have a look. But if it is a raised lesion and you are concerned, that it comes to the RAU or CRESS at at Denmark Hill, and we will see it that day. And the other thing, just to remind everybody, and I'm sure I'm just, you know, talking to myself really, but the distortion does not mean wet AMD. Drusen, big drusen, will give you distortion. It makes it's fairly obvious it's going over the hills, so it will so therefore the retina will be distorted. So examine carefully. Only refer wet AMD if you really think it is wet AMD. And that's really what I'm saying. We must work together to ensure happy and safe patients.
Thank you very much for that. There are a couple of questions. Let me just put my camera back on so you can see me again. There are a couple of cast questions that came through in the chat. If I can just ask if that's okay.
Sure.
So an attendee asked whether if blood sugar control is the key to diabetic disease, then why are GPs not really encouraging self-testing anymore?
Yeah, that's a good question. I mean, diabetics have really suffered through COVID because they couldn't get to see their GPs, they couldn't get near their GPs. There is many diabetics. It makes you want to just cry when you see them, that they've tried to see their GP, they've called their GP, they're phone number 49 in the queue in their GP, and when they get to number 1 in the queue, the system says, oh, I will reboot now. And they never get their appointment. So it is very difficult. And there are a lot of them. It's a common disease. But you're quite right. I mean, the key is sugar control, and it is distressing really that in a developed country such as the UK, we are still seeing, you know, bad proliferative retinopathy. I would, however, say that most of the proliferative diabetic retinopathy, we do see in patients who have either been through a period of poor control or who are poorly controlled. So, you know, that is a team effort. The control of your diabetes is it's seeing the medical team, making sure that you're on the adequate treatment, but also making sure that you don't go home and eat a Mars bar.
Unfortunately, that is part of it, isn't it? Okay.
Yes.
So, another question asked is, are you getting a lot of post-op complications from outside HES clinics into the emergency?
Yes, we are, and it is very frustrating because we will happily, well, not happily, because we would rather all of our post-op patients don't have any complications to go skipping out the hospital looking happy. But if they, you know, if for example, I've done a cataract operation and there's a patient who has cystoid macular edema, then I will happily see them. But we cannot offer a service to the independent treatment centres who also get postoperative macular edema in their patients. And indeed, the CCG have very much said to us, it is actually imperative that King's, and I'm sure the same with St Thomas's, see their patients and their patients only, and the independent treatment centres look after their own patients.
Okay, thank you. Back to wet AMD and low vision. So this is the last question, and then we'll move on to the next section of our evening. If low vision and wet AMD is confirmed, do we still refer for assessment or not, as it's not within NICE guidance?
That's a very good question. It's a really good question. I would say if it looks like a big macular scar, you can certainly still refer it, because if, for example, a patient is, let's say, 618 count fingers, the benefit of them coming to see me is I can register them as partially sighted. So I can then kick in all the support mechanisms from our eye clinic liaison office, as our low visual aid team and things like that. Obviously, if you're concerned, you know, you can always send us a picture. I loved, you know what retinal people are like. We love looking at pictures. So we'll happily look at any picture at any time. But basically, it's just to manage patient expectation, because if you sense, it's very distressing when some poor little old lady comes up and she's count fingers with bilateral disciform scars, and she's been sent whizzing up in a taxi because I'm going to suddenly make her better. And of course, I'm going to then have to say to her, actually, I can't do anything. And that's very distressing. So it's just a management of expectation. And you could say to somebody, look, it doesn't look like they'll be able to help you, but I will, ask for one of my colleagues, I could ask for Bavina or Joe's advice, or I could just, drop a referral off, and we would probably look at that in our optometry-led macular assessment clinic, not in one of the consultants' clinics, and our optom in that clinic would decide and then say, Emma, could you just register this lady as visually impaired?
Would you prefer that to be sent to you via the standard ERS pathway, the routine pathway?
Yeah, I think so. If you're certain it's scarring, if it's white and it looks like a crunched up tissue, then it's probably scarring. If there's an enormous hemorrhage, it's still worth sending it acutely, because if the hemorrhage clears, we might have luck. So if there's a big macular hemorrhage and the vision is count fingers, then I would send it urgently, because we might be able to get rid of that blood.
Okay.
Thank you.
Okay, brilliant. So thank you very much. I'm going to stop recording now if I can.